So I'm looking forward to working with you as we are with our county colleagues moving this project forward. It's important for healthcare. It's also important for this community for economic development and jobs that can be created through the spin-off of having this modern new hospital. It's 3 years ago now, in a hall not too far from here, Ambassador Hall, where Dwight Duncan appointed Teresa Perusa, Tom Porter, and myself to a task force to consult the community, and we were asked 3 questions. Would a new single-site hospital improve the delivery of acute care in our communities? Would a new single-site hospital provide value for money? And is there community support to move to one hospital? We had advisory committees that involved obviously folks from the hospitals, from the business community, from labor, from the college, from the university, from CCAC. We consulted, we had open houses, we run the phone-in shows, we had meetings, dozens of meetings with community groups at the university and at the college as well. And after several months of consultation, we concluded that there was broad support to move to one modern acute care hospital. There was good healthcare reasons, and David's going to talk a lot more about that in his presentation. And there were good cost reasons. The master plans for the 2 hospitals were, if they had gone ahead with that, would have been around $2 billion. And we would have had a renovated hospital downtown, and we might have had a smaller, brand new hospital next to Met, but there'd still be issues. We don't have, under the current hospitals, we don't have enough facilities for the students, medical students. And I remind people, it's not just the medical school for doctors, we have a nursing school, and we have an amazing health sciences program at St. Clair College. Our report was finalized and released in November 2012, and we recommended that, that what we heard was that the community supported moving to this one new modern acute care hospital. There was an issue that obviously had to be settled, and one that those of us that have been Windsor all our lives know has bedeviled the system for a long time, and that's the issue of governance. Little did we know on the task force that at the time that we were consulting the community, David and his colleague Ken Dean at Hotel Dieu and the hospital board chairs were already discussing the issue of governance, and very quickly came to the conclusion that the system needed to be realigned and that acute care would be under Windsor Regional Hospital, and that, and I forget the appropriate name for it, but post-acute care or whatever it is called, that the rehab facilities and mental health out at the TAFOR campus would be with Hotel Dieu Grace Healthcare. And I think those of us, again, that have followed this for many years know how difficult that work could have been. So all of us in Windsor need to tip our hats and thank the 2 CEOs and also the board chairs and the board members overcoming that problem and immediately coming forward with answering the governance question. So progress has been significant. Modernization of the whole healthcare system in Windsor-Essex is going to happen, and Gary from the LIN is going to talk about the community capacity study that's going on right now. So I look forward to working with the community, and I guess the one thing is the consultation processes all along the way have been very, very extensive. And I think at the end of the day, what we really want is for the people in this community to say, that's not Windsor Regional Hospital, that's our hospital. That you'll be able to see that the consultations have had an impact, that they're reflected in the actual product in the hospital at the end of the day because of the consultations and because of your input. So I appreciate everyone that has come out tonight, and now I'm going to turn it over to David, who has the guts of the presentation here.
Thanks, Dave. When Mayor Dilkens was introducing Dave, I leaned over to Gary and I said, he's retired? I didn't know that. Unlike Gary and myself, Dave Cook is a pure volunteer. You have to recognize his value and his efforts with respect to this. Dave and I, along with Gary, we've probably done, I mean, we're closing in, I think, on 30 presentations to groups across Windsor, Essex. And Dave has been at every single one. Dave has committed his time with respect to even the task force. His involvement's been phenomenal. So I really want to thank Dave Cook for everything he's done with respect to this project. It is in his heart to move this ahead, and the reasons for needing it for Windsor, Essex. Dave breathes that on a daily basis. So thank you, Dave, for everything. And thank you, Mayor Dilkens, and we have some city councilors here. Thank you for inviting us to do this presentation in the city. As we stated, we've done numerous in the city and the county across, and we really appreciate this facility and appreciate the University of Windsor as well in supporting us here at this facility. This is a rather gorgeous facility here. So very impressed with it, and acoustically it's kind of neat too. I think if you stay a little later, Dave's going to start singing at the end of this as well. So, but just to back up a bit, as outlined and as Dave outlined where we were as organizations and what the government said, and I'll back it up a bit, probably in about 2008, both organizations, Hotel du Grace Healthcare Hospital at the time and Windsor Regional Hospital, were asked by the government to put forward a plan, a future plan, what they call a master site plan, looking out 10, 20, 30 years out into the future about what healthcare looks like for both organizations, for our community, and what the infrastructure needs would be. And as Drew mentioned, and as Dave mentioned, we had to look at our current infrastructure and how we were going to plan. So what happened is Hotel du Grace Hospital put forward a plan to the government for its existing property located at Olette, and Windsor Regional put forward a plan focusing on Met. We had done a separate one for the campus on Prince Road, the Tayford campus, and that's actually come to fruition now with respect to that master site plan, but we did one for Met as well. So those were presented to the government. And from 2008 until about 2011, they got these proposals and they were looking at them. And they were saying, this doesn't make sense. They were done separately. They weren't done together. The Erie St. Clair Lynn looked at them and said, this really doesn't make sense. Folks, you really look at something different. You need to look at the possibility of one state-of-the-art acute care hospital for your community. So that's when Dave and Teresa and Tom Porter came together and did the work Dave indicated with respect to going out to the community and finding out the value of moving towards a new single-site acute care hospital being state-of-the-art. Now, at the same time that the government asked for that to be done, they also, as Dave indicated, the hospitals knew what was coming next, knew that the government was going to say, you need to do something from a governance point of view if we're moving in this direction. So in my mind, and I'll highlight this a little bit later, I know there's individuals in the Ministry of Health that are generally not that keen on this project overall. And I think at the time when they said to the hospitals, we're going to support this planning, so Dave's groups put forward the task force report, they issued a letter to us. And they said, we're going to give you money to do this planning on one condition. You have to solve the governance issues. You have to solve the operational issues, not when the hospital's built, but now, before you even start this planning. And I know there's certain individuals that were saying, hey, they haven't done it for, what, 100 years? No chance. This is going nowhere fast. Gary would probably agree with that, but this is going nowhere fast. And it took the leadership of the hospitals through the boards to say, no, we're going to look at what's in the best interest of the community. We're going to put aside all that. We're going to focus on what our community needs. And we desperately need a new state-of-the-art acute care hospital for our community. Our community deserves nothing less. So that's when the boards came together, Hotel Dieu Grace Hospital, Windsor Regional, and said that's what we're planning towards. By return mail, indicated to the ministry, we've solved the governance issues, this is the way it's going to work. And that's the plan that's now, where Windsor Regional is responsible for acute care services, Hotel Dieu Grace Healthcare now responsible for post-acute care services, continuing to work together, but under that formula, and that the new hospital would be under the governance and operation of Windsor Regional Hospital. So just who we are now as Windsor Regional, just give you some perspective of what we are as a hospital. We have over 30,000 now total admissions on an annual basis. We perform some 40,000 surgical procedures on an annual basis. We have approximately 140,000 ER visits, and we're going to talk about that. That as we move towards the new acute care hospital, we don't want, and we're not going to have 140,000 emergency room visits going to that hospital. And we're going to talk about how and some other things that are happening in the province of Ontario for that not to happen, and that are better for the community. Our annual budget's closing in on $500 million a year. Our annual capital budget is some $30 million. Now, one thing a lot of people don't know is that we receive, similar to other hospitals in the province, about 86 cents on every dollar we need, we get in funding from the government. We then have to find that other 14 cents ourselves. So I know kind of a touchy subject that's out there is the ways we raise this money is through the parking. That's how we get that difference. So the $7 a day we charge goes towards that difference. The semi-private rooms, or the rooms that goes towards that. And that's no different than any other hospital in the province of Ontario. And what we really appreciate is individuals like yourself in our community supporting the hospital through fundraising efforts and making donations. It goes directly towards what we get $0 from the ministry for, and that's for new or replacement equipment. So most recently, a great campaign that was led by the community through the Windsor Essex Cancer Centre Foundation was for the Da Vinci robot. And that was huge. Huge because that resulted in patients who were in the past having to leave Windsor to go to London, to go to Ottawa for services, stayed in Windsor to get their care. Now, what these statistics show is one of the things we are for Windsor and for the province is now, because of this, we are the third largest community teaching hospital in the province of Ontario. We are the 11th largest hospital, period, in the province of Ontario, out of over 140 hospitals. Where that comes into play is we have a voice with the ministry. We have a voice through our Erie St. Clair Lynn with the ministry to advocate for things. So for instance, one of the great things that happened immediately after realignment occurred with the support of the community was the thoracic cancer surgery issue, where we were going to lose that to London. And that issue, so everyone knows, was going on for years before realignment occurred. That issue was percolating, and there was comments with respect to it's going. And then it was eventually going to go. It was clearly the community standing up saying no, but also saying to the government, things have changed. We cannot lose that. And we cannot lose that because of the realignment now being the 11th largest hospital in the province of Ontario. We can support that now. And they agreed. So that's a huge difference. That's just one example of many. Men's health, as I stated with the Da Vinci, we're the 25th Da Vinci robot in all of Canada to have that. We are the first program, men's health program, that's funded by the government of Ontario. We have urologists who are with us, who are being asked to speak across Ontario, across Canada, across the world with respect to the success of our men's health program. That's huge. That's huge for our community. And that's happening now. So we have now over 4,000 employees at Windsor Regional Hospital, one of the largest employers in Windsor Essex. We have 500 professional staff. Professional staff are physicians, midwives, some nurse practitioners, and in my opinion, the most important part of the whole group, 650 volunteers Without them, we couldn't run the hospital. They are invaluable on how they support the hospital. Hospitals are complicated places. Hospitals come with a lot of stress. And our volunteers, and some of them are in the audience, do a phenomenal job for us. And they help reduce that anxiety for our visitors, for our patients, for our families who come into that stressful environment. And they're amazing and invaluable individuals. So Windsor Regional Hospital, this is who we are right now with respect to all these services that we provide for the Erie St. Clair Lynn. From London down, regional cancer care, regional cardiac care, critical care, trauma, family birthing center, renal program, on and on. Back probably about 8 to 10 years ago, though, Windsor Regional Hospital was struggling financially and struggling clinically. Our clinical results weren't the greatest. Financial results were not good at all. We were struggling. We're working hard. Staff were doing an amazing job, working their tails off, providing patient care, but we really were struggling. And when we would have, every so often, when you have entities coming in that would accredit us, one of the things they would say to us is, you're working really hard, just need to focus. You really got to focus. So we took a step back and said, okay, who do we want to be? Where do we want to go as an organization? So one thing that inspired us was this quote, and we used it, and it's, just paraphrase, it's man, write a better book, preach a better sermon, make a better mousetrap than his neighbor. Though he built his house in the woods, the world will make a beaten path to his door. And we used that to drive our organization because there was a healthcare system that was built in a place called Rochester, Minnesota. And for those of you who are not familiar with Rochester, Minnesota, it's pretty much in the middle of nowhere, Minnesota. Has a population now, even today, of about 100,000 people. At the time, it had pretty much zero population. And two brothers had this quote, and they put it up in their office door, on their office walls. Actually, if you walk into my office, I have this up on my wall. And these two brothers talked about creating a healthcare system. Not a facility, a system. They needed the facility, though, to do that. So they built their facility in Rochester, Minnesota. Those brothers are the Mayo brothers, and it's the Mayo Clinic. So as an organization, we said, if the Mayo brothers can build one of the finest healthcare systems in all of the world, in Rochester, Minnesota, with 100,000 people, what could we do in Windsor, Essex with, hey, we got 300,000 people? What are the possibilities? So that drove our staff, and that drove all of us to say, we can do that. What was great is about 2 years ago, our staff was invited to do 3 clinical presentations at the Mayo Clinic. And when our staff went to do these 3 clinical presentations to an international audience, we were told when we arrived that we were the first Canadian hospital to be invited to do a presentation at the Mayo Clinic. And our frontline staff were the ones who did it, which is phenomenal. So that drives us to today. I mean, ever since those dates, our clinical results are clearly getting better. First of all, they're public for the world to see. Second of all, financially, is we're running on about 8 straight years of balanced budgets, which is great during this time to do that. And I commend our staff of living and breathing it because we followed quality, and we said quality was going to be our focus and the finances would take care of itself. So, what does the future hold? Just so you know, you're a special audience. Dave, Gary, and I talked about this before. We're going to take tonight, it's a big surprise, we're going to announce the site of the new hospital tonight. No. You ready? No, we're not. Sorry, if you came here to hear the location of the site of the new hospital, you're at the wrong meeting. We're not doing that. What we're going to talk about is the new hospital, what it brings, or what it will bring for our region, and the benefits, and what else is going on in the province of Ontario. What else is going on in the world with respect to new hospital development, and the possibilities for us. So what does the future hold? So before we start talking about the new hospital, what we're doing now as an organization, as I stated, we have now the Olette campus and the Met campus for acute care. See, the media is leaving because I announced that we're not announcing a site. So we have the Olette campus and the Met campus for Windsor Regional Hospital. And they were governed with two different organizations, but previous to about 18 months ago. So before we start even talking about designing a new hospital, we're at early stages. We're not even into design phase yet at all. What we have to do is what we call standardize and optimize. And we started this process about 9 to 10 months ago in earnest. And actually, we started it before October 1st, 2013, when we realigned as organizations, knowing this was coming and having to develop a plan. The goal is to standardize the operations between both campuses. So you as a patient, when you walk into either campus, the experience you have is the same. We're not moving towards the lowest common denominator for the experience. We're moving towards the highest common denominator. Is we want to have that experience to be outstanding, like our vision, outstanding care, no exceptions. Now, that does a few things. Number one, it creates teamwork. It gets two groups of employees that technically never worked hand in hand to be in the room together and working hand in hand. And it's frontline staff coming up with that standardization. It's not me coming up with this is the way of the world. It's the frontline staff involved. And it's from the patient's perspective. And how do we know it's from the patient's perspective? They're in the room. They're part of the process. And some of them actually are here tonight. They're actually there at the table, talking about from their point of view what their experience is coming into the hospital and what they would like to see from their perspective moving forward. So that's the first thing it does. Second thing it does, it's going to drive the design of the new hospital. We could contact an architect today and he or she could design the most beautiful hospital in the world. Will it be functional? Will it be operational? Might be, might not be. So what we need to do is standardize our operations to the point that they will drive the design. That we will take our operations, which will be brought to best practice, hand it to the architect and say, now you design a hospital around this, not the other way around. And that's what we're doing. It's going to take a lot of work. A lot of organizations, so you know, that have kind of come together and are in the process of moving towards a new hospital, they kind of cut onto this late, and we know there's some across the province that are kind of scrambling now. They're into the design phase. Some are already building hospitals and are like, wow, we got to get, eventually we're going to move into this place and work side by side. The last thing we can afford is that when we move into the new facility, to have, for example, two admitting clerks sitting next to each other and saying, well, this is the way I admit a patient at Olette. No, this is the way I admit a patient at Met. No, we got to have one way. And it's got to be focused on the patient. So that's what we're doing right now. And it focuses on, clearly, people, processes, and results. So with respect to the new hospital planning, as I stated before, we're moving ahead with the planning. We're at a very early stage. I'll outline later on how early we are with respect to the process. We're being looked at by the province because they're very interested in how we have reached out so early on in the process to the community. They're very interested in the fact that with the community, we got them involved at a stage with respect to the concept of even site selection, asking the community to be on the site selection committee, having all volunteers, board members, and individuals from the community, because you got to remember, just like Dave Cook, our board members are volunteers. They're not paid. We put ads in the newspaper and people apply to be on our board. So that's open to the public. everyone on that site selection committee is volunteers. Not only did we stop there, but then we said to the public in general, we put together the general criteria, and we asked the public for feedback. We had over 600 responses with respect to that, providing feedback. That feedback was used to not only modify the criteria, but also weight the criteria that was used in the site selection process. One of the things about the site selection process is we know at the end of the day, wherever this hospital is going to be located, it's going to be wrong. And why is it going to be wrong? Because every single square inch of Windsor, Essex has been suggested for the location of the new hospital. There's going to be a group out there that wants a new hospital in their backyard, and guess what? It's not going to be in their backyard. Then there's going to be a group out there that doesn't want the hospital in the backyard, and what? They're going to look up, and there's going to be the hospital. But we got to move on behind that. Because, folks, if we don't, we're going to lose out. We really are. So I'm now going to highlight what else is going on in the province of Ontario. And there's little cards that are going to be available for you. If you haven't signed up or haven't gone to this website, it's called windsorhospitals.ca. And I'd ask you to go there because there's a lot of information. I would love to be able to pick all you folks up and go to Humber, in Toronto, and see what's going on there. I'd love to pick you up and take you to Oakville. I'd love to pick you up, take you to West Bloomfield, to what Henry Ford's doing. That's just not practical. So what we've done with the help of Allison Johnson, Allison joined the team, and what Allison is doing is she's going out to these facilities, bringing this information back and posting it on the website. So you'll see a lot of informative videos there with respect to what is out there, what's happening. And so you know, folks, in Ontario, what all of you are paying for. You're paying for Humber. You're paying for Oakville. So it's about time Humber, Oakville, the rest of the province, pays for us and builds a hospital for Windsor, Essex. So I'm just going to highlight some of the videos, short segments of them. The first video is from Dr. Gary Ng. Dr. Gary Ng is our Chief of Staff. And Dr. Gary Ng talks about, from a physician's point of view, the pressures that are out there for physicians and the attraction for professional staff in different jurisdictions. Remember, a physician can make the same money in Windsor as they're making in Toronto, making in Ottawa. Same amount of money. They want to look at something different. And one of the things one of the things they want to look at is with respect to something different, something like designing being part of the future for the new hospital. And one of the great examples, sorry, Jane, I'm going to pick on you here. Jane Boyd's here, and Jane knows this, is we were recruiting some young urologists to the city after the unfortunate passing of Jane's husband. And he had actually started recruiting them before he passed. And these guys were interested in Windsor Regional Hospital, and they were interested because they were looking towards the future. They were saying they wanted to be part of something exciting. They wanted to be part of looking towards designing and building a new state-of-the-art hospital. They could practice urology wherever. But they picked Windsor, and they picked Windsor on that dream and that vision, and they picked Windsor for also the men's health program. And lo and behold, we get the men's health program in a Da Vinci robot. There's only 25 of them across Canada. So these guys came, and I really appreciate Jane and clearly Dr. Boyd for his leadership in that regard, but that gives you an idea. So what Gary talks about is what else is out there, what the pressures are, and what attracts people, and what happens if technically we do nothing.
If we do nothing, that would be very risky in terms of the evolution of healthcare. It will go backward because once we are stagnant, we'll stand to lose what we have in terms of physicians, nurses, and other healthcare providers, because there are other medical centers that would love to have some of our physician staff from here.
So what I'm going to highlight now, I'm going to go across the province of Ontario and look at what's been going on basically over the last, say, 5-8 years with respect to hospital redevelopment, kind of highlight some of the things, or all of the things, a lot of things on the internet site, windsorhospitals.ca, and just highlight some of the videos. So here's a map of our lovely province of Ontario, and the first hospital I am going to highlight is Humber River Hospital. Now, Humber River is similar in size to what we're looking at. It's going to be opening actually up this year. And one of the things that Humber River focuses on is in our 2 acute care hospitals right now, out of our bed structure, we have approximately 20% of our beds are private rooms. 80% are not private. And when you look at new hospital design today, new hospital design talks about actually the reverse, is you should have 80% private, 20% semi or wards. The reasons for that are multiple: infection control issues, patient comfort, allowing families to spend more time with their loved ones in the hospital. Our infrastructure today doesn't support that. Now, over at the Prince Road, with Hotel du Grace Healthcare, what was developed at that campus is it's 80% private rooms at that campus. And that was in the design for that. One of the huge benefits, because I can tell you, pretty much on a daily basis, I get phone calls from family members saying, and from patients, could you please get me out of this room, this semi-private or ward room, put me in a private room, because I can't stand my roommate. He's snoring all night. He's making noise all night. I came into the hospital to get better, and I'm getting worse because I can't sleep. Or number 2 is, I'm having family come and visit me, and there is 0 room in the room. My dad, about a year ago, had his hip replaced, and he was at Olette, and he was in a semi-private room. Pretty much, I mean, I'm a pretty big guy, but I went in the room and visiting my dad with his friend, his neighbor, and when the physician and the nurse had to come in, I had to leave the room to give them room to get into the room. It's just not workable. So the Chief Operating Officer of Humber River talks about what's in their design for their patient rooms.
80% of our patient rooms, so it's almost all of them, have a 3-piece bathroom, a single patient room, and a family area. And this is great news from an infection control standpoint. You are no longer sharing a bedroom, sharing a bathroom, and breathing the air of somebody else who might have some kind of an infection. But not only that, our rooms are created such that the families become part of the stay. And if they wish to stay with a family member, there's a sleeping area, there's a little family alcove, it's got its own lighting, a plug to plug your computer in. So we think that that's going to be a much more comfortable environment for our patients and their families.
So one of the benefits also outlined, as you can see in that little area there, is for family members to stay with their loved one 24/7, have their own sleeping area to be with their loved one. Can't do that today unless you want to sleep on a chair, but you're not reclining in order to do that. Now, in our private rooms, you have that ability somewhat, but definitely not in the other rooms, not at all. So it's not comfortable. Family can't be with their loved ones right now. And again, for the patient comfort issues, as indicated. And one of the things is, new hospital construction, even for the semi-private and the ward rooms, and forgive me now if I offend you with this, but the rule from this infection control practitioner said this is the rule and this is the lingo they use. It's 1 butt per toilet. So in semi-private rooms, each patient in that room, even though they're in a semi-private room, has their own toilet. They don't share a toilet. Toilets are the quickest way. We could have someone there cleaning them 24/7. It's the quickest way to spread infection. Wardrooms, 4 toilets for patients. That's new hospital infrastructure. That's the environment we live in. That's the environment that continues, from an infection control point of view, continues to morph into that. So another project that happened back in 2011 is North Bay Health Center. Another project that happened in the province, William Osler, back in 2011. Another project, a little closer to home if you've been there, it's actually quite a phenomenal expansion they did, is Blue Water Health. Another project is Halton Healthcare, opening this year, about the same size of what we're looking at as a facility. And also, I'm going to take a stop here. We're going to focus on the next one, which is the Niagara Health System that was opened in 2012. Now, one of the great things about Niagara that I wanted to highlight, and this is kind of the question sometimes we get asked, and so you know, this presentation has evolved over time in about the 30 times we've done it. Based upon a lot of the feedback we get, we try to, you know, and same with the internet site, try to update information with respect to the feedback, to hear from the community and engage the community, get their feedback, as provide the information. So one of the things we focused on is Niagara Health System. They came together. There was, I think, 3 hospitals that were brought together to build this particular facility. And one of the concerns in the community at the time in Niagara was, wow, if you ever had some type of outbreak, if you're in one facility, aren't we kind of like limiting our ability to operate in this one facility? Actually, and I don't mean to scare people, but it's quite the contrary. The way our facilities, the infrastructure we have now, if there's an outbreak that occurs at one of our facilities, there's no way we're going to be able to keep it contained within that facility, let alone spread possibly to the other one. It's just impossible. Not going to happen. The way they're being built now in Niagara is going to highlight is the issue with respect to air handling systems, and the fact that in a hospital, now they build them that you segregate the different areas of the hospital and they have different air handling systems. And that way, if you have something occurring in one part of that hospital, you can still operate the rest of the hospital without having to worry about the spread of that to other parts of the hospital. So Niagara focused on that. The first video, though, they're gonna talk about this concept. So you know, when before I get to the second video on Niagara is going to focus on that. The first video on Niagara is going to focus on the issue we have currently when patients come in from the community and the lack of access to these private rooms. What the staff have to do on a daily basis is like a Ouija board trying to figure out where these patients are going to go, because unfortunately a lot of the patients come in from the community with community infections. And some of them we have to assume they are going to have an infection until it's ruled out. As a result, we do our best to segregate them. But when we only have 20% of our private rooms, most of them are taken up, well, all of them are taken up actually right now, with respect to patients that either brought in an infection or unfortunately got an infection at the hospital. The rest, we have to kind of segregate as best we can in semi-private or ward rooms. So the first video going to highlight is from a infection control specialist at Niagara who has that 80% private, 20% semi, and she talks about the benefits of it from an admission point of view and not having to move patients around on a daily basis, trying to accommodate people in order to facilitate trying to not have a spread of infection.
As professionals, we all reference the best practice documents, but usually have to make adjustments with the older facilities to make them work. Here, those processes work, and those processes are established into the build. My favorite feature is the 80% single patient rooms. It enables you to put the right patient into the right bed at the right time. So what can happen is you can have a patient here in ED who develops or comes in with an infection that we need to put in additional precautions. And it enables us to place them in that room right away rather than cohorting them very closely to other patients.
Patients are safer here now?
Absolutely. The trend is down on transmission of antibiotic-resistant organisms and organisms such as C. difficile.
So again, the next video is going to highlight this concept of the air handling systems at the same facility.
So one of the design features of this building is that the front end of the building is all ambulatory, and as you move deeper into the organization, the intensity or acuity of the patients increases. So at the very back end of the hospital is all the acute care areas, At the front end is all the ambulatory care areas. What that allows us to do is separate the front end of the hospital and continue to provide ambulatory care if there's an outbreak and we need to isolate the back end of the hospital for infectious diseases. If you think back to SARS in 10 years ago, one of the issues that arose then is that hospitals were basically closed, and they could look after patients, inpatients, but they couldn't, or they weren't able to look after ambulatory care patients. In this organization, you can actually isolate the two, because things like cancer care or kidney care require frequent visits to the hospital, and you can't not do them in an outbreak.
So some other projects that have taken place, there's multiple. Mississauga, Burlington, Cambridge, Markham, Hamilton, London, Oshawa, Kingston, Belleville, Peterborough, just to name a few. The one thing all those have in common is the fact that everyone in this room paid their share towards building all that. So it's about time all that pays its share towards building a state-of-the-art acute care hospital for Windsor, Essex, because again, we deserve nothing less as a community. Because I can tell you, if we don't move along with this process, there's other jurisdictions out there that would love to build a new acute care hospital and jump ahead of us in the queue. For example, Ottawa. City of Ottawa has assembled some land. They want a new acute care hospital. Where are they at right now? They're behind us in the queue. We start getting caught up, and the politicians have been great with respect to saying this. We can't get caught up, folks, in where this hospital is going to be. We have to trust the site selection committee and the work they've done, and trust that and move forward, because we deserve nothing less. And I know we're going to be proud of their work. I know it's going to be good. Again, is it going to be perfect? No. Are we going to make 100% of the people happy? No. But we can't have nothing less for our patients, for our families, for our staff to have this. Now, one of the videos is Dr. Jerry Cooper. Jerry is at the Windsor program of the Schulich Medical School, and Jerry talks about the benefits of a new acute care hospital from a learner's perspective.
The current facilities in Windsor in terms of the hospitals, they meet the needs, but just barely. We're certainly looking ahead to that day, hopefully will come, that we have a new, brand new physical plant here in Windsor. It would mean the world to our learners, to our faculty members. It would certainly be a shot in the arm for conducting research here as well. You know, you need space to do these things, and you need the proper equipment, and we don't always have those things at our disposal at the present time.
So one of the other things that has come up in some of our sessions is this concept of the size of the property we're looking at. And, you know, unlike being in, say, Manhattan or Toronto or Chicago or Buffalo or Vancouver, we're in Windsor. And what we have to look at is serving our region. And that's what the ministry made it very clear. We are a regional hospital for our region. So as a result, one of the things that they want to look at, too, from a planning perspective, is they don't want hospitals to build a new hospital and then be landlocked when you got to develop it in 20 years, 15, 20 years, and be stuck. They don't want to do that anymore. They've been there. If you have the ability, they want you to have the ability to expand on the existing piece of property, as well as look to the future. Because again, we get one shot at this, folks. This is not something the ministry wants to revisit in 50 years from now and say, oh, guess what, Windsor, Essex, you get another new acute care hospital, go through this process again and pick another site. They want to be able to say the site that you select now is not only good for 10 years from now, but it's going to be good for 20, 30, 40, 50 years from now. So you got to look out with respect to that. So one of the areas that we highlight, one of the videos, is from Oakville, and the main planner for Oakville site talks about the property that was used there and the reasons that the ministry now looks at with respect.
In Ontario, to have the capacity to grow without disruption to operations is critically important. And having the capacity in land mass, having capacity in building mass to do that intelligently, you're spending the right amount of money at the right time versus too much too late. I think that having the capacity to grow to 702 beds, which we have on this site, would protect the healthcare for this community well into the future.
So I'm going to come back. I'm going to hand it over now to Gary Switzer, who's going to be talking about the community capacity plan and the work that's going on through the LIN and with a bunch of community agencies. And then I'm going to talk about something that we're also going to be making part of that community capacity plan, where I said earlier we're going to highlight on emergency services. I'm going to kind of focus on that for a bit. So Gary?
Hi, thank you, David. Before I get into my presentation, this process that Windsor Regional is going through with the community is really groundbreaking, and there's no pun intended there with the site selection at all, but it's redefining how decisions are made with respect to building infrastructure for healthcare. That the model that they've employed with, starting with Dave Cook getting out into the community and checking the community's feelings for, do we need a new acute site? Should we move forward? That really informed the ministry and the LIN that this was a go. To have the leadership at the two hospitals from a governance perspective come together so fast with their staff to say, we can develop a better model of care for our community, groundbreaking, where other parts of the province have contacted us to ask us for the terms of reference on what did they do and how did they do it and who led it. So it's really exciting news, and it's the power of that leadership that I believe will get this hospital built. So Sandra Livrier, I have her name on this presentation. I'm going to do the talking. Sandra Livrier is really our feet on the ground, working with all the stakeholders in the hospitals to move this project along. The LIN's role is that the ministry has devolved the responsibility for capital planning to us. And what that means is that our board has to approve this entire process and every step along the way. Now, that fits right into the wheelhouse of why LINs are here. This responsibility was devolved to the LINs because decisions need to be made as close as possible to those people that are being affected by it. You get a better view of Windsor when you live here than if you were downtown Toronto. So it's in our wheelhouse. I always say the good news is we're here and we can't hide. So I'm looking forward to this. Our vision is very simple. You know, we want better care, better experiences, and better value. We're all taxpayers. We're all after constantly improving care, and David talked about that, what his organization is going through to do that. From an experience perspective, this is where my phone rings. People talk to me about the experience they had, and it usually happens when the transitions of care, when they're moving from one organization to another, and the ball's dropped or it's not that well coordinated, which I'll talk to later, and better value for money. It's very expensive, our healthcare system, 46 cents on the dollar for a tax dollar, and our costs are increasing all the time because we're constantly improving. So I'm going to talk about the community capacity plan. So what David talked about is very important, a new acute site. And hospitals, most of us in this room are going to spend more time in a hospital visiting family and friends than we're ever going to spend in a hospital. If you are admitted, usually you're in there for 5 or 6 days. They fix you and they move you out to the community to get better. So this is part of the conversation that we're having now is what's in the community to make it better, to make you better? What else is needed there to give you greater access to services? So we have to decide that now. And David talked about a good example, the robotic arm for prostate cancer. Years ago, not too long ago, 10 years ago, you'd be in the hospital for 5 or 6 days. That's changed now to less than 2 days. That increases capacity, improves quality. Changes like that, we need to plan for the future. This hospital, we hope, will be built within 7 years or so, but it's got to last 20, 30, 40, 50 years, and you have to anticipate what services will be in that hospital, but more important, what services are going to be in the community. The community capacity plan, as I said, is really to ensure that everything is coordinated in the community to ensure that the best care is provided when you leave that acute institution. And also to ensure that the acute site has what it needs to perform. And that when the patients leave, the same level of care is continued in the community. So we have a process. We put a committee together of community members that provide our various stakeholders, and it's chaired by the CEO of the CCAC, and it's co-chaired by the CEO of the Alzheimer's Society. Two strong leaders in the community to help lead a group through this planning process. We will be hiring a consultant to assist us, and why, you'll say, why a consultant? You know, you're the LHIN, you have all these health professionals. Because you need specialists who do this. You need specialists that do this type of work, not only in Ontario and in Canada, but around the world, because they're going to give us the best ideas that are out there. We looked at, this committee had over 50 different procedures or processes or programs that they wanted to look at that could be managed in the community to provide better care in the longer term. That was boiled down to this list of 11. And I'll just give you some examples that may resonate with you. For those of you that have had to go to a hospital for cancer treatment, there's new developments now for low-risk patients where you can receive your treatment at home. What that means is you don't have to arrange that drive from a family member. You don't have to rely on public transit, be it if you live in a city or in the county. And you can have it in the comfort of your home, and the professionals will come to you. That's very important. For those of you that have had surgery and had to go to the hospital for your workup, that can be done in a satellite location off campus. It does not need to be in a hospital. It can be in your community for that workup. Dialysis. Today, there's dialysis happening in retail malls. And I look at a lot of our hospitals, they have reserved parking for dialysis patients up front, but they still have to walk over snow and snowbanks. And now they're in strip malls in Ontario, elsewhere, and around the world. So how do we plan for that? How do we ensure that we have the right capacity in the community to make that work? Emergency visits, David mentioned 140,000. That's significant. You cannot have that at one site. It is impossible to provide the quality of care and the response time when you have those volumes. We will need an urgent care center somewhere in our community to satisfy those low acuity needs. People will show up to have their stitches removed. People will sprain an ankle at a baseball game. They don't necessarily have to go to an acute site to have that work done. They need more of an urgent care center, and David will talk about that. So these are a few of the examples that we really need to work through. We need to ensure that we have the best practices and we are building the capacity in the community. Because the last thing you want to do is build a hospital and all these assumptions, oh, when they leave here, they'll have that service. And if the service isn't there, they're going to spin back within 7 days back into the hospital. And that's why this is so important. Just remember, your average length of stay is 6 or 7 days in a hospital. The rest of the time for your care, you're in the community. And that's why it's so important for us to ensure that that's there. So an example of how we wrap around the service, you'll see the new acute site here and how they really have to interface and have the patient flow really tight with our subacute so that once you have your hip done, on day 3, you should be able to leave and go into rehab, either into the community or into a subacute site. Might be sites in your neighborhood that you can go to. We call them a satellite site, or it might be something else. That the purpose of the acute site is to fix you and move you out to someone to get you better. And I'm going to steal a line that I heard a couple of days ago, and get your life back together. And that's the importance of having community capacity. Wrapping around there are some of our social services, the Community Care Access Center, the CMHA, the CHC. These are all services that people need once they leave an acute site to provide that wraparound care. It finishes with primary care. Now, I'm the first one to say we need a lot of primary care reform. We need to ensure that we can transform our primary care network to ensure that we have access when we need it, that the patients can see their primary care doctors rather than going to an emergency room and waiting for a couple of hours to have a small ailment fixed. All this is transformation. This takes time. But the beautiful thing about this is, and our board recognizes it, you cannot plan an acute site unless we have the capacity and the community identified and we put investments there to make it happen. And so, although the timing process for the acute site is longer, we are going to go lockstep with our planning processes to build the capacity in the community. So our next steps. We're going to continue the work that we're doing. We're actually doing an RFP for our consultant this month. The consultant will come in and we'll have consultations with stakeholders and professionals throughout the system and the public. And with the goal to, I'm going on the next slide already, with the goal of after the community engagement is to come back next year with a community capacity plan. That community capacity plan will then need to be costed out, and we'll go through the process of approving that as we go through the various steps for the acute site as well. This goes back to you. Thank you.
Can you hear me in the back with us? Yeah, perfect. Okay, good, thanks. So as Gary indicated, community capacity plans taking place right now to talk about this is much more than just the acute care hospital. This is about the overall system and making it more accessible to the patients of Windsor, Essex, that they don't have to all go to the acute care site. And when they leave, they don't have to go back. They can stay out in the community. One of the things we're focusing on is this issue of emergency room visits. And the issue, as Gary indicated, we have about 140,000 emergency room visits between the two campuses right now. That number, about 8,000 of them actually go directly to our, we have what's called no-be triage. So it's really about 130,000 because about 8,000 go if you are past a certain period of time in your pregnancy, you bypass the emergency department altogether and you go directly to the floor. And that will continue in the new hospitals. People don't have to wait in the emergency department. One of the interesting concepts, though, that's out there that's actually in action is in Toronto, where they have what's called an urgent care center. We have to remember, as Gary indicated, not only patients stay in a acute care hospital for only 6 to 7 days on average, a lot less. About 90% of the patients that go to an emergency department go home. They don't stay, they don't get admitted. Only about 10 to 12% of our patients from our emergency department get admitted to an inpatient bed. So how can we make that experience for 90% of our patients better? So what happens right now at our 2 acute care sites is if you're there and you're part of that 90% who are going to be going home, and some of that 10% individual comes in by way of trauma, or we have what's called a Canadian triage acuity scale, a lower, like a 1 or a 2, that they require immediate assistance. The resources from that emergency department get taken to take care of that patient. What happens then is that 90%, their time gets delayed. And it's not an issue of, well, throw more doctors, throw more nurses. That's not the issue. The issue is how do we focus on that 90%? So what they did in just with Trillium Healthcare is they focused on that 90% and they created what's called an urgent care center. And an urgent care center, their urgent care center actually sees 60 to 65,000 patients a year. There's a video, it's a little longer, it's about 3 minutes. I'm going to show it to you in its entirety because I think it's very important to hear this concept, and I'll talk about it a little bit more.
Johnson for Windsor Regional Hospital. Today we're heading to Toronto, Ontario to check out a model of urgent care that's helping to reduce hospital wait times by keeping patients out of emergency rooms. Welcome to the Queensway Urgent Care Centre. It's a former hospital that closed in the late 90s. Today it's run by the Trillium Health Partners Hospital, and the old emergency area is used to treat patients with serious but non-life-threatening issues.
It's an emergency services center that provides care to a focused segment of patients, and it's those patients that are less sick or have less acute medical issues. It's not a center that's open 24 hours a day, and we do not receive ambulances like an emergency department would.
But they do treat 65,000 patients a year here, and these are patients who might otherwise be stuck waiting in the hospital's nearby emergency departments.
So the goal is to provide a strategy to help with emergency department wait time reduction. We've developed an alternate site of care that's appropriate for many patients that don't necessarily require the resources and everything that goes along with running an emergency department.
And they can get the results right away. This model is working so well, a group of Windsor Regional emergency care leaders came along for the tour today to check it out.
How far can you actually move that?
Maybe to about there.
Because it's not a hospital, there are no beds to admit patients, so you wouldn't come here if you're having a stroke or a heart attack.
We do see a lot of patients who come with musculoskeletal complaints, back pain, broken bones, sprains, cuts.
But don't confuse this with your typical walk-in clinic. The former hospital still has a full-blown set of diagnostics.
Through diagnostic imaging, laboratory services, and that allows the physician the confidence to treat and diagnose a patient as to whether they require follow-up care in an acute setting. If it's a cold, if it's a flu, if it's an earache, then that's more for the walk-in clinic. But here we look at people with suffering headaches or nausea or abdominal pain, something that can't be easily diagnosed without supportive diagnostics.
Staff are all emergency trained, and working at both the acute site and the urgent care site gives staff the ability to keep up their skills and to be able to rotate and enjoy a little bit of variety.
All right, so say I've broken my wrist and I go to the Credit Valley Emergency Department right now. How long can I expect to wait to see a doctor and be out the door?
The average wait time could be from beginning to end about 4 hours to come in, get your diagnostics done, see the physician, and treatment, and by the time you leave.
Okay. Same injury, I come here.
So it would be significantly less time, where our average time for lower acuity patients could be 2.5 hours. Again, depends on why you're coming in.
So possibly half the time to come here.
Could be, yep.
Shorter wait times than a hospital emergency and more advanced treatment than a walk-in clinic.
We like to say this is the best kept secret in the Greater Toronto Area.
And it's a model that could have legs closer to home, as this group sets out to map out the future of our emergency healthcare in Windsor, Essex.
They still have the ultrasound, the CT scan, and from this, it becomes more than a walk-in clinic. It becomes somewhere where real medical decisions can be made, and that takes the burden off the department where patients need to be admitted. And I think we can take some aspects of that away from our model of Windsor and incorporate that in our design, and I think we can kind of win from coming here today and seeing how they do it.
So as highlighted on that video, this concept is working to the point that when you're there, there's some patients that come in and they bypass, they'll show up and they'll show where they're from, and they'll say to them, do you know to get here you pass like 3 hospital emergency departments? They said, yeah, like you said, it's the best kept secret in Toronto. It allows that patient to have focus. Now where this is located, Queensway is about 7 kilometers from the Trillium site. So the concept is you don't put this immediately attached to the new acute care hospital. You put it where the new acute care hospital is at. You put it where the acute care hospital is across from it, in the sense of 5 to 7 kilometers away from it, to service a population, for a population to go, to have access to these services, not immediately attached, but to service Windsor, Essex. And it's been a great success. It relieves the pressure off of the emergency department itself, and it provides faster, more efficient care for those patients. A patient who does go here to this urgent care center in Toronto, that maybe the patient came in and maybe they are having a heart attack. they immediately get transported to the acute care site. EMS transports them. So that happens. If during their stay at the urgent care center, things just get worse and worse for them, then they go over to the hospital, get immediately admitted into the hospital site. This will be run and governed, operated by, as indicated here, Windsor Regional Hospital, to be the same physicians and the same nurses that are in the emergency department, will also serve the urgent care center, and they move back and forth to get that experience back and forth and to have that expertise. For us, kind of in Windsor, we hear urgent care, and it's kind of a misnomer because, again, we have some centers, they're walk-in clinics, and they say urgent care. That's not urgent care. Those are walk-in clinics. This, as stated, is totally different. So this is something that is going to be part of the submission when we submit for the new hospital. This is going to be included. The new hospital does not happen unless this is part of it. And that's guaranteed. So something exciting, something that works. So where are we at in the process? We're really early in the process. We're here. Stage 1 actually has a Stage 1A and B. Stage 2 is a process, and then you got Stage 3 to actual construction implementation, Stage 5. So we are very early here. And the amount of community consultation we've had for here, as Gary stated, for a provincial perspective, is groundbreaking. And the reason it is, and the reason we wanted to do this and get the community engaged, is, as Dave Cook said, we don't want this to say Windsor Regional Hospital. We want it to say it's our hospital. It's your hospital. It's our community's hospital. It's going to be with us for generations to come. And we have technically one chance, and we've got to do it right. And that's what we're committed to do, and that's why we've gotten everyone involved as early as we can. The critical part, we're going to be submitting Stage 1 to the government, to the LIN, actually, first around May of this year. We're going to be doing that before site is selected and announced, and the reason for that is the ministry and the LIN wants this project to keep moving. They really like our site selection process. They're confident in it. And as a result, generally, they don't allow projects to move to Stage 2 or even submit Stage 1 until site selected. But they didn't want our process to slow this down. They wanted our process to continue because actually we've been called by a couple other hospitals in the province who are in this process right now, and they're asking us, how are you doing it? We're hearing some great things about what's been happening in Windsor with respect to site, because I'll tell you, a lot of jurisdictions, there's a couple people in a room that look at a map and do this and say, guess what? There's a site of the new hospital. Let's go. We said we're not going to do that. Now, along with that comes a lot of people clearly getting involved, giving different opinions, which is great. So maybe the other places that didn't do that, they just pick it, and they just figure, you know what, we'll deal with the consequences of that as compared to getting the community involved. Our group said no. We want to get the community involved as early as possible, get them involved in every step of this process. The critical thing is getting to Stage 2. Right now, the question is not only if we're going to have a new hospital, but when we're going to have a new hospital. You move to Stage 2, the only question is when. The question of if is answered. And that's why it's critical. We got to move this ahead. So yeah, there'll be naysayers out there saying, well, the government's going to run out of money and et cetera, et cetera, et cetera. Yeah, hey, that might all happen. But no matter what happens, we're going to be in the process. We're going to be in the queue. And if it slows down or speeds up or whatever happens, we're still in that same queue. No one's allowed to jump over us. That's what we need to have happen for our community. And that's why it's so important to move forward. With respect to the preliminary designs, when we get to Stage 2, especially near the end of Stage 2 to Stage 3, is with preliminary designs. This concept of when we're getting to design the hospital. Again, we're going to get the patients involved. We're going to get the community involved in that. We're going to use what we learned from the SOP process, but we're going to start mocking up patient rooms. We're going to start mocking up different areas of the hospital and get patients to come in, kick the tires, give us ideas, give us their thoughts. Because there's a lot of experts in the community, and we got to draw that information in. Because again, this is going to be a hospital for our community for generations to come. And that's why it's so important we get it right the first time. So again, I ask you to go to windsorhospitals.ca if you haven't already. Please go, sign up. Every time we put new information on, a video or any information regarding what's going on in the province of Ontario or updates with respect to the project, you will be emailed. You will be notified that we're adding new things. So please go to this website. It's a fantastic website with respect to a lot of information on the project. And if you go there, this is basically what you're going to see is some information you can click on and get highlighted with respect to the information on different videos and some history with respect to the project. So on behalf of Dave, Gary, myself, I want to thank Mayor Dilkens for inviting us here tonight. Really appreciate him reaching out to us and saying on behalf of the residents of Windsor to come out and talk to you again. This isn't one stop. I mean, Dave and I, it seems every time we go to one of these sessions, we'll get an email asking us to go to 2 more. So we have at least 2 a month, and we're going to continue to do this, continue to update the project as we go along.